My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health in Public Housing. Thank you for listening to this podcast. Thank you for attending this activity. This activity is supported by the Health Resources and Services Administration, HRSA, and the U.S. Department of Health and Human Services as part of an award to provide service and training and technical assistance to health centers located in or immediately accessible to public housing. The contents are those of the authors and do not necessarily represent the official views of nor an endorsement of by HRSA, HHS, or the U.S. government. And thank you for coming to or listening to the NCHPH podcast series. I am very pleased to discuss diabetes, and we have a great person who is going to discuss with us the role of pharmacists and share her experience with health centers and what she's done for underserved populations. So diabetes is a HRSA priority, and the health center program launched the Diabetes Quality Improvement Initiative to help patients control their diabetes. As you know, diabetes poses a unique challenge for the HRSA Health Center program because 1 of 7 patients has diabetes and nearly 1 in 3 of those has uncontrolled diabetes. Patients with a hemoglobin A1C at 9 or above are more likely to experience complications. So the diabetes control measures for 2020 are we are planning to increase adult and pediatric weight screening and counseling by 5%, increase the number of health centers meeting Healthy People 2020 goals by 5%. We are trying to reduce new diagnoses by 5% and reduce by 5% the number of patients with diabetes with an A1C value more than 9. And lastly, we are trying to reduce by 1% the disparities gap between racial and ethnic groups with the highest and lowest rates of diabetes. At the same time, we would like to discuss the role of pharmacists. Pharmacists are the most accessible healthcare providers, and they are key players in the betterment of patients' health, not just in terms of screening, but in the lifelong management of diabetes. Pharmacists also are able to provide counseling about monitoring glucose levels and how to manage out-of-range levels, including development and action plan for what to do if your levels go too low. And pharmacists can help patients select the most appropriate hypoglycemic management strategy on an individual basis. Pharmacists can also counsel on an appropriate diet and exercise routine to complement medication management in treating diabetes. So we are very pleased to have today Teresita Lawson. She is a registered pharmacist and a community diabetes educator, bilingual, bicultural, registered pharmacist licensed in New Jersey. Her role as a clinical pharmacist for Sioux Health Center included implementation of a continued quality improvement initiatives for the clinical pharmacy services program at Sioux Health Center. She precepted 6-year PharmD students APPE rotations for Long Island University, Rutgers University, and Fairleigh Dickinson University, and her effort helped to contract Sioux Health Center as a faculty site for Fairleigh Dickinson University College of Pharmacy. She has since retired from academia and is now actively consulting in the pharmaceutical industry and volunteers her time in helping to educate patients with diabetes, live productive and full lives by overcoming barriers to care. So Teresita, thank you for joining us, and we have some questions for you. And the very first question is, what are the challenges to improve diabetes measures in special and vulnerable populations?
Well, Jose, thank you for having me. But to address these challenges, we have to look at the prevalence of low health literacy, right? So that's definitely up on the list as far as challenges that we face in helping our patients improve their diabetes. There have been many studies on health literacy. One that I find very informative is the one done by the U.S. Department of Education back in 1992. They did a NOW survey, and they found that most people that had a low level or level one of health literacy were those in our most vulnerable populations, like the elderly, like people with limited education, ethnic minorities, recent immigrants, and people of low income are those that are the most vulnerable to low health literacy. Another issue that I think affects our patients is the ever-increasing complexity of the medical care system. We expect them to navigate at high levels and understand instructions that are truly very difficult to understand if you have low health literacy. Complex medication regimens, they're forever getting more and more complex, and we expect patients to understand how to manage those medications. We expect them for diabetes to perform complex tasks like measuring their blood glucose, measuring their blood pressure, understanding their numbers, and knowing how to modify their diets and avoid hypoglycemia and take steps to avoid hypoglycemia. These are very, very complex tasks that present a big challenge to people. Also, we have to look at psychosocial determinants of health. These are things that can be economic barriers, social conditions that present barriers for people to get care for their diabetes. The CDC does have a great resource on their site for social determinants of health. I really encourage people to visit them, and also encourage people to look at a publication that was publicized in 2003 as part of an educational program on health literacy. And it was published by the American Medical Association, and it's called Health Literacy, a Manual for Clinicians by Dr. Barry Weiss. I highly recommend it, even though it was printed back in 2003. What he brings up in that educational piece still holds true today.
Excellent. Thank you, Teresita. Basically, low health literacy and the amount of information that vulnerable population need to handle and housing and food insecurity and all that stuff are the challenges, and not only for public housing residents, but for any low income and vulnerable population. Thank you.
Absolutely. You're welcome.
And in regards to the challenges to reduce childhood and adult obesity in a special population, what do you see the challenges? Or what are the challenges?
Well, in reducing childhood and adult obesity, certainly we have to look at health literacy as well, right? Mm-hmm. So there is no magic bullet, but research and literature suggests that a multi-level approach is what seems to be a better way of reaching folks in these special and vulnerable populations. So really it needs to be multifaceted, right? So we need to look at the community. We need to look at what's happening in the home, their social environments, and develop approaches that meet these individual barriers as well, like genetics and behavioral issues that individual patients may have. Underlying social and economic barriers are also a big issue that we need to look at holistically. So, for example, low-income areas are less likely to have healthy nutritional choices in their area. They're more apt to see fast food, which really isn't a healthy choice. They're getting better in recent years, but it's still not a healthy choice, right? Lower income areas are usually more akin to having higher crime rates. And therefore, people may not be so comfortable going out for walks or engaging in, for example, community gardens and things of that fashion. So it may predispose residents of those areas to a more sedentary lifestyle as well. And then less access to affordable weight management programs and gyms. You know, there are many areas where there are very, very few options. There's no, for example, public parks where people could go for walks. So that's the social economic aspect of it is definitely a challenge, especially when it comes to children. We also have provider shortages, right? So in those areas, we need more safety net providers like community health centers to improve access and quality for the underserved populations. And we also need to look at recruitment and retention of community-based participatory partners, if you will. So things like girls and boys clubs, YMCAs, community health workers, PAL organizations, schools, and worksite initiatives, as well as churches, might be good resources that we should be looking to tap into to provide that multi-level approach, if you will. And then also interdisciplinary collaborative models of practice. These create the linkages that would make our interventions more optimal. People like pharmacists, dietitians, and health coaches, if we link into those resources in the community as well, I think we can at least begin to reach that 5% decrease that you spoke about in the beginning.
Yeah, you know, and you and I have discussed the need to increase patient education as well, right? And we have, or at least health centers serve patients from different ethnicities, and the cultural beliefs are, you know, a big issue as well. I mean, there are in some cultures, carbohydrates in general are a big part of the diet, you know, and sometimes we have patients that do not know that beans, for instance, are rich in carbohydrates. You know, people tend to believe that we are just talking about added sugar, you know, like sodas and things like that. But we also need to educate them, you know, that there are some food that is part of the culture, part of the daily diet that are carbohydrates.
Yep. I mean, cultural competency as well as language competency is important because not only low English proficiency, right? They are more vulnerable because they don't understand. They come from a different culture. They eat differently. They come to this country and they may not be able to find their cultural food either. But if they do, normally speaking, coming from a Spanish background myself, I know that our diets are not balanced by any means. So to try and overcome that cultural challenge, if you will, I don't want to call it a barrier because it's our culture. It's the foods that we love. But how can we teach them how to enjoy their foods? The foods that they love in a healthier portion, in a healthier balance. And I think that is very, very much achievable, but we need to educate our patients on and reach them in their communities in order to help them do that.
That's you, and you are correct. And this is a really good segue for our next question, because we've been talking about health literacy and how difficult it is for diabetic patient with either low health literacy or low English proficiency to understand the instructions and the prescription labels and the food labels.
Well, first of all, I don't know about you, but the food labels are becoming smaller and smaller. So regardless of whether your proficiency is high or low, they're difficult to read, period. They're very busy. Even prescription labels are extremely difficult to read, in my opinion, as a pharmacist. They're very, like I said, busy. They're not uniform. You go to one pharmacy, they have a different label from another pharmacy. So there's no consistency in how we deliver our prescription medications, how we label them to be consistent with low literacy patients. On top of that, the medication guides that we give our patients are at a very, very high level, too high of a level of literacy. And we really do need to look at that. Just because you give a patient a piece of paper doesn't mean they're going to read it. As a matter of fact, most of my patients have informed me that they never even take a look at those papers because they're just too complicated and they're overwhelmed already with their conditions, let alone try to understand literature that they have trouble reading. So that, on top of the fact, as mentioned earlier, medication regimens are becoming more and more difficult, more and more complicated, more on-hand management is required. I believe that part of the challenge is that we need to become more culturally competent and language competent in our pharmacies as well. If we expect our patients to perform complicated tasks, such as those that we require of them in diabetes, we have to make sure that the literature that we deliver is not only delivered at a very low level, preferably, in my opinion, third grade level, the highest you should go, but also be delivered with a face-to-face counseling and education to explain to the patient, well, what does it mean? If a label says 1 tablet twice a day, well, what does that mean? 1 at 9 and 1 at 12? I had a patient that was taking metformin that way because the label said twice a day. So discrepancies exist. Misunderstandings are way too common. And I believe that as healthcare professionals, we should be able to really address this. This shouldn't be as a difficult thing to do, to lower the literacy level of our literature. Make sure that we take 5-10 minutes to at least explain what the label says.
Thank you, Terry. And you are completely right. I mean, this is something that is not, there is no universal label or labeling. And
no, IHI did introduce a universal label, but it hasn't really been widely adopted. And I feel it's because of the cost issues involved in implementing such a change. And it takes everybody to come to the table and say, okay, we're going to adopt this label nationally. It's not an easy feat, but I believe that the universal label is one technique that we could use to help our patients understand prescription labels better and avoid medication errors.
Correct. Now, I would like to move to a different area, and there are some studies showing that pharmacists is a growing group, and probably by 2025 we are going to have enough pharmacists to cover all these issues, including health issues, including diabetes. As a pharmacist, what evidence-based programs were you involved when you were working for Zufall Health Center?
Well, when I started with Zufall Health Center, we started as a result of being part of a HRSA collaborate called the Patient Safety and Pharmacy Clinical Services, or PSPC. They brought me on, and we started with a simple brown bag initiative where we would have our patients come in with all of their medications, and I would review those medications with the patient. It started very small. Trust is something that not only we have to develop with our patients, but also with our fellow interdisciplinary team members, right? So it took a little while for provider buy-in, but they started to refer their high-risk patients to me. And as the program progressed, my panel of patients increased, and the program graduated and evolved through that process. We definitely used the pharmacist patient care process, which is our pharmaceutical guideline on taking care of patients. We also use therapeutic guidelines like the ADA and the Endocrine Association as well. We also use the ACDCES 7 self-care behaviors to model our diabetes education program by. And when the center decided to target NCQA certification, they also put me in charge of project for NCQA accreditation. And also, as a result of the successes of that program, the program was very successful. I didn't have any more room in my panel to see more patients, but I'm very proud to say that we were one of 25 sites that were selected to participate in Project Impact Diabetes, which is a project that was launched back in 2010. And it was the first national diabetes self-management program conducted by the American Pharmacists Association Foundation. And it was in partnership with the Bristol Myers Squibb Foundation Together on Diabetes Initiative. And that program was also extremely successful. We were highlighted by the Centers for Health Law and Policy Innovation of Harvard Law School, and we were highlighted in their report for New Jersey, which was an analysis of New Jersey's opportunities to enhance prevention and management of type 2 back in March of 2014. So the program was very robust, still continues to be, I believe, even in my absence. And I believe that the aspects of the program were very successful in meeting the barriers that patients presented with.
Thank you, Terry. This is something that is when we were having the introduction, we discussed the role of pharmacists, and what they do for patients with diabetes. And when a patient, a diabetic patient, goes to a health center for any visit, any kind of visit, they see the doctor or the nurse, or probably they go to a behavioral health um, um, interview or session, and the last person, you know, that they see they have contact before they leave the health center is the pharmacist who is basically the last the healthcare professional they have contact with. So
Hmm.
what is the role of a pharmacist during the encounter or during the visit with a patient with diabetes?
Well, as with any patient, you know, screening is definitely an essential piece of what pharmacists can do. So if you have, for example, someone that is obese, or has hypertension or dyslipidemia, you know, those patients, that also needs to be screened, right? Um, so pharmacists play a very important role in screening for those conditions, for the comorbid conditions, as well as monitor how they're doing with their diabetes. If the patient is pre-diabetic, I had many patients that presented that weren't diagnosed with diabetes, but had uncontrolled hypertension or had uncontrolled dyslipidemias, or had obesity, that we were able to get into care simply by screening them. Also, as pharmacists, we're very, very involved in preventative care and vaccinations, and point of care testing is another area where pharmacists are really having expanded into already. And also, we're more, we can give the patient more targeted education on the medications that they're taking, why they're taking them, what's so important about lifestyle and behavior modifications, why should they change their diet or modify their diet, and how can they do it within a cultural, respectful way. And pharmacists are, because of their ties to the community, are very, very good at doing these targeted patient education centers. Also, you know, there's a lot of talk about provider shortages, especially in the areas where the vulnerable and special populations are. And that lack of accessibility, the pharmacist can fill that gap. They can catch issues with the with that patient that perhaps the patient hasn't even been to see a PCP, so we're able to encourage that patient to get the care that they need and follow up with their physician if they haven't done so. Because of the fact, like you said, the pharmacist is the last person usually that the patient gets to see in their community. Well, that pharmacist has a way of linking patients, right, to other disciplines within that community and to community resources if needed. So typically, these are the types of resources that pharmacists can help patients tap into. And of course, we have comprehensive medication management, which is really the art of optimizing the patient's medication by making sure that each medication is assessed for its appropriateness. How effective is it? Is the patient in harm's way with this medication? Are they taking it right? Have they suffered side effects? And they also take all of these medications and the treatment regimen into consideration with respect to their comorbidities as well as what vitamins and over-the-counter products are you using? What have you purchased on the internet that maybe you should have a discussion about with your doctor, or that may impact or interact with one of your medications? So this becomes also very, very important in transitions of care. Most of the time, pharmacists are the first ones to see patients come out of the hospital. They go straight from the hospital to the pharmacy to fill their prescriptions. And there they can identify, whoa, this is very, very different to what you were taking before. And then they can address these issues with other members of the interdisciplinary team. And also, last but not least, they can monitor and follow up with these patients on an ongoing basis. Patients don't need an appointment to see a pharmacist. They could just walk into their community pharmacy and see their pharmacist if they need to. So we're able to monitor them a lot closer and have more opportunities to catch issues and provide a better environment for therapeutic success. And we are in a better position to minimize treatment failures as well as hospitalizations.
Thank you, Teresita, and that is great information. And while you were discussing the role of pharmacists, and you were discussing medications and different medications, and make sure that that you have a list of medications. Came to my mind, and is the fact that sometimes we have patients who are either taking over-the-counter medications, or these natural remedies, that they find that they are not approved, but patients tend to believe in this kind of medication that can also have side effects. So we need to make sure, that we, in addition to the prescribed medication, we ask for other type of medication that probably the patient is taking or is on, and they forget to mention it. When they have...
Right, because to them it's just something that you could. It's like purchasing a gallon of milk. I want to go and get something at the pharmacy, and whatever it is that they want to get or been advised by somebody on the news or on the internet or by a friend, and they don't know how that medication can interact with what they're taking in their treatment regimen. So definitely that there is a loophole that pharmacists fill with that service. With over-the-counter medications, you're always looking at interactions and duplications. There's a lot of medications that are available over the counter now that weren't available many, many years ago. So now there's even more of a risk of patients duplicating prescriptions that they might have received from their doctor with something that they could purchase over the counter without a prescription.
That is correct. And Teresita, we are coming to an end. And is there any promising practice you would like to highlight, or anything that you would like to mention to the health centers listening to this podcast today?
I think that first and foremost, we need to really encourage pharmacist exposure to patients. So I believe that freeing up the pharmacist's time in order to provide these essential clinical services to our patients is far more important for the overall health of these populations. Certainly, pharmacists are taking on more and more expanded roles. I think it's important that they embrace those roles, become more comfortable with speaking to patients and doing physical assessments, educating and reinforcing the medication regimens, and working very closely with interdisciplinary teams in order to be able to say, okay, this person presented with depression, let me refer them to our behavioral health specialist or back to their PCP for treatment. We can make sure that those patients don't go through the cracks. So definitely utilizing the pharmacist more often, and in order to fill in those gaps and making sure that patients don't fall through the cracks is the main thing that I would like to highlight. But I know that, and coming from my experience with the health center, reimbursement has always been an issue. My position, for example, was completely granted. So provider status is something that I think all of us need to advocate for, not just the profession of pharmacists, but everyone involved in the care of patients, because it is a very necessary service. They are the medication experts. We are the ones that are going to be able to help optimize that patient's treatment and hopefully get them better and avoid very expensive trips to the ER and hospitalizations, if we can.
Thank you, Terry. And I would like to thank Terry Lawson, pharmacist and diabetes educator, for her time. She has shared her experience on health literacy and her experience working with special and vulnerable populations. So thank you so much for your time, and thank you so much for the information. And thank you to all the our listeners. Thank you so much for listening to this podcast. Please visit our podcast series. You can find additional information on our website, www.nchph.org. We are the National Center for Health and Public Housing. We are funded by HRSA to provide training and technical assistance to health centers, with a special focus on those located in or immediately accessible to public housing. All the content and all the information that we provided today are all the comments and information is the responsibility of the participants and then those who participated in this activity, and are not HRSA's points or HRSA's interaction with and do not represent HRSA's point of view. So thank you so much for your participation today, and thank you again, Terry, for all your great information and expertise.
Thank you for having me, Doctor.
Thank you.